to all of you. I'm Dr. Jyoti Maheshwari. On behalf of Bombay Psychiatric Society, I welcome you all for this informative and very interesting session on bipolar disorder. And today we have two eminent speakers with us, Dr. Malay Dave and Dr. M.S. Reddy with us, who are going to enlighten us on two different aspects of any kind of psychiatric illness. Like say, as a clinician, we are more interested in diagnosis and treatment. And as an academician, we need to know what are the latest updates. So we are going to get the feast on both the issues. From Dr. Malay Dave, we are going to know about what is the latest update on the neurobiology. And Dr. Reddy is going to speak about the challenges which are there in the treatment of mania. So to continue the program further and to introduce our speakers, I hand over the virtual mic to Dr. Austin. Right, over to you, Austin.
Thank you so much, ma'am. Thank you so much. Good evening, everyone. We have two distinguished speakers today. First among them is Dr. Malay Dave. Everyone in Bombay must already be knowing him. He's been there doing psychiatry practice since 24 years. He's asked me to introduce himself as an amateur neuroscience surfer. But at his level, I think he's gone to the professional level already. So those who know Dr. Malay Dave, I mean, my first interaction with him, I was in 9 inches Ashwini. And that time, civil world apne liye ekdam alag tha. So we like, civil world ka clinic attend karna chahiye. That is when one of my colleagues told me that Nair Hospital, there's one Dr. Malay Dave who takes excellent clinics. That is my first interaction with him, sat for the clinic, welcomed us, and after that kept on learning from him over the years in whatever lectures he has taken. So thank you, sir. We'll not waste much time and we'll straight away start with the lecture because we have a very brief time and so that everyone can get enlightened. Okay.
Sure. Thank you, Dr. Austin. Thank you, Dr. Austin, for the kind words. Thanks, Bombay Psychiatry Society, for inviting me to speak on the neurobiology of bipolar disorders. Avinash, as sir mentioned, he did change the topic a little bit, but my topic was basically a play around with words. Initially, it was neurobiology of bipolar disorders from the cerebral cortex to the clinic. And now he has changed to what the clinician must know. But I don't think that really changes the content of what I'm going to say. Without much ado, I'll start sharing my screen. And here it is. So there are quite a few slides, and of course, I'm not going to get into all the details of each and everything that we currently know about the bipolar disorder in terms of its neurobiology, what we know, what is happening. It's quite a lot, frankly, and well, it might not be really important for clinicians, so to say, because much of it is in the research domain still. We do not have those findings which are translatable into daily practice as of now. But we'll have a look, we'll glance through all those things, we'll have a bird's eye view, we'll not really get into details of each and everything. So I'll start. Okay, so as I mentioned, our clinical therapeutics have not kept up with the neurobiology because over the years we have had a few drugs that we have been using religiously for the treatment of mania, for depression, for maintenance, so to say, and a few of them have got added actually for the bipolar, not for the depression part of it. So we are not much ahead in terms of what we were in terms of medications over the last few decades. And yes, so there's a tremendous gap in the neurobiological knowledge as we know what is in the works, what is happening, and clinical treatment, evidence-based treatment, what we can offer to our patients. The illness itself is pretty heterogeneous in its presentations. There are all sorts of findings in bipolar patients. Even there are, as I would say, low level or low intensity findings in the relatives, first degree relatives, and so on and so forth. The illness itself overlaps with a lot of other illnesses, both physical and psychiatric. The illness is characterized by numerous episodes and a very prolonged duration of the illness. But in the course of these multiple episodes and the duration of the illness, there is a lot of disability, dysfunction, endocrine and neurotrophic abnormalities, inflammation, treatment resistance, medical comorbidities, shortening of the telomeres, frontal cortical abnormalities, so on and so forth. So a lot of things happen apart from the disorder, apart from the symptoms that we are so familiar with. So straight away, I'll get to one of the main understandings of current times is the aspect of neurodevelopment and bipolar disorder as a development, as a disorder of neurodevelopment. Now, when we look at this, when we look at the basic etiology of bipolar disorders, well, it is not. It doesn't go like a story which says that once upon a time there was a king. There have been a lot of things happening even to this king before the king became the king, and so on. And there are a lot many factors which are to be understood, looked into. Even when we are sitting in our clinics with a patient in front of us, we need to go into some details regarding the neurodevelopmental aspects. And so we have an interplay of a lot of factors even before the disorder itself is manifest in the form of mood symptoms. So we have inherited factors like genetic factors, epigenetic factors, developmental factors like developmental milestones, especially cognitive and emotional development, baseline background brain alteration in terms of gray and white matter anomalies, heterotopias, clinical signs, not clinical signs, that is what our phenomenology is, but in terms of neurological soft signs, dermatoglyphic anomalies. So basically, this kind of a problem as regards neurodevelopmental aspects is there right from the time of conception, throughout pregnancy, where some other things get added in terms of pregnancy or prenatal complications, maternal stress, so on, around the time of birth, from birth and childhood in terms of early life trauma, and so on and so forth. And here is where the patient will first come to us and then probably stick to us or one of us when it comes to bipolar disorders. But neurodevelopment says that we need to look at all these things, all the different shades of all the different colors before we encounter the first mood episode. Right. When it comes to genetics, we understand that bipolar disorder is very highly heritable, that is 70 to 90%, which means that there is a very strong genetic component. So at least the disorder can be explained in an individual up to 70 to 90% as a genetic etiology, and the other part, that is remaining 20 to 30% as having environmental influences. A lot of things going inside an individual's brain, the neurons and the nuclei. Of course, we know that the rates are elevated among biological parents of adoptees diagnosed with bipolar disorder, 10 to 15% of first degree relatives. And these first degree relatives can have a mood disorder, which would be from the depression, from the spectrum of depression to bipolar to schizoaffective, means predominantly mood complaints. However, there are also increased rates of alcoholism associated and anxiety disorders associated and schizophrenia. Some studies have said that. Age at onset, psychotic features, frequency of episodes, the type of the disorder, whether it's going to be manic or depressive polarity of the first episode, suicidal behavior, and response to lithium treatment has now been found to be strongly familial in nature. Neurocognitive traits like resting state EEG and deficits in facial recognition have been understood. And these are not only present in some of the patients or many patients of clinically diagnosed bipolar disorder, but even in unaffected relatives who have not been diagnosed with any mood problem. And these are the kind of features which tell us that this disorder doesn't exist as a disorder of the person itself, but is a kind of a spectrum of different things seen in close relatives. Even the daily activities patterns also seem to run in families. When we look at genetic factors, BDNF, that is brain-derived neurotrophic factors, COMT, catechol orthomethyl transferase, SLC6A4, that is the serotonin transporter, are the genes deciding these three proteins are the main focus of genetic studies. When we look at the current studies, we are not going to have studies, genetic studies, which are there in very few patients, but we have what are called as genome-wide association studies, where the entire genome of that individual is looked at and searched for associations and findings which could lead us to an understanding of what is exactly contributing and in what amount to the development of bipolar disorder. So all of the markers so found are common, and each confers a modest risk. So there is nothing very specific that kind of becomes very predominant when we look at it and we can say, aha, this is it. No, there are a lot of genes in the entire genome which have got small effects, and together this symphony of genetic findings will confer the risk, increase the risk, and present as the bipolar phenotype. The associated single nucleotide polymorphisms lie near genes that encode signaling molecules. Now, what it means is, now what do these genes do? When we are looking at these genes, one of the three of them are mentioned here: BDNF, COMT, and SLC6A4. Now, for all practical purposes, they are not found only in bipolar disorders; they are found in other disorders also. So there must be some common thing underlying the etiogenesis of many psychiatric disorders. So when we look at this single nucleotide polymorphisms, they basically are probably responsible for signaling molecules, so neurotransmitters, ion channels. So they kind of decide how much calcium is going to enter the cells, neuronal growth factors, and other important molecules. And many of the same genetic markers have been implicated by genome-wide association studies of schizophrenia. And that's what I said, that both of them could be sharing a lot of genetic factors. Well, to make it very simple to understand without going into too much detail, of course, which nobody is going to remember after this half an hour, this is what is the state of genome-wide association studies till about 4 or 5 years back. In current terms, this is a very new publication, so pretty much up to date. Some things might have got added, but maybe the triangles, the small triangles, the triangles like this are not going to change soon. Now, these are all the chromosomes that are there in the human cell, all 22 autosomes and X and Y. Okay. Now, when we look at these chromosomes, we see these small triangles. These small triangles actually point to the locus of the genes which have been regularly identified or associated with bipolar disorder in genome-wide association studies. So if we look at all of them, there are very few chromosomes which have got no small triangles near them. So otherwise, as I said, pretty scattered picture. So single nucleotide polymorphism heritability studies have generally been far below those of twin studies. So when we look at those heritability factors, which I mentioned here, 70 to 80, 90%, when we look at these more specific studies, the heritability estimates are down to about half. So typically in the range of 30 to 40. Copy number variants. Now this copy number variants will look at effects which are single gene effects, but more robust effects. So it's like if something goes wrong in this gene, then there is going to be a more deeper effect on the etiology, unlike SNPs, where you need many of them with small effects. So we have something called as chromosome 6 11.26p, that is the short arm chromosome 16 on this locus, a duplication. And this duplication, if it is present in patients, in people, then the risk is tenfold. But it also confers a high risk of schizophrenia and intellectual disability. So we are not the wiser whether it is specific for bipolar disorder. Now, as if that was not enough, some genetic factors, but what we also know and what recent studies have also shown us, this is basically a diagrammatic view of many systematic reviews on epigenetic findings. And what would they show us? These different colors are different parts of the brain. So this orangish color is frontal cortex here. The blue one is DLPFC and temporal. We have this yellow prefrontal here. Green one in the medial part is the anterior cingulate cortex, and C is the cerebellum. So these 5 regions have shown a lot of what we can say epigenetic markers, which means that in these areas of the brain, even though there are no gross mutations found or single nucleotide polymorphisms or CNVs found, because of epigenetic functioning or because of epigenetic variations, especially demethylation, DNA methylation, okay, in various genes, this is a kind of an epigenetic map. Means, again, if we see in multiple areas of the brain, multiple genes having multiple kind of epigenetic effects, and when this kind of a thing works together, then we have an individual. Because even when there is an epigenetic change, doesn't mean that the individual is going to manifest with the phenotype of bipolar. There are certain protective epigenetic changes also, and it is again something like a huge cluster of things, epigenetic changes happening at the same time. So without going into any specifics, we need to know that these 5 areas: prefrontal cortex, frontal cortex main, anterior cingulate cortex, prefrontal cortex and temporal lobes, and cerebellum are the sites of epigenetic changes which finally lead to the brain of an individual, which predisposes to develop bipolar disorder. Now, when we look at genes and epigenetic factors, it will translate into something which is sometimes seen. And these are minor physical anomalies, which are morphological features without any medical significance. So there are certain peculiar features about the faces, limbs, fingers, tongues, palates. Okay, so this facial physical anomalies, minor physical anomalies, are predominant prevalent in individuals with schizophrenia. Now, one thing that we'll notice is that when this kind of changes, whether it's genetic changes, epigenetic changes, this subtle physical signs, both in terms of minor physical anomalies as well as neurological soft signs, they also appear on a spectrum. Means most of them, if they are found, would be in schizophrenia, intermediately in terms in bipolar disorders, and minimum in healthy control. So this point number 4 here, prevalent in individuals with schizophrenia to an intermediate extent in bipolar disorders and infrequent in healthy controls. This continuum is seen in a lot many neurodevelopmental factors in bipolar disorders. So bipolar disorder kind of occupies, I would say, if you are looking at the chessboard, it is actually the king, the queen being schizophrenia with the most power. Okay, and there is a higher prevalence in both bipolar 1 and type 2 disorders. Then neurological soft signs, again more frequent in individuals with bipolar disorder compared to healthy controls. But as I mentioned, that spectrum of schizophrenia max, intermediate bipolar, and healthy controls least is always sort of maintained. Dermatoglyphics is an old thing. Newer studies have not really given us anything more specific than probably what we knew about so many years back. After that, after this subtle physical anomalies, we need to look at early development and cognitive functioning, because this is the background on which the disorder actually develops. So a lot of studies are there on early development and cognitive functioning, because people feel that if you're able to pick these things up earlier, they could serve as some kind of a marker by which if we can develop preventive measures, then the individual will not go into a long chronic problem that is bipolar disorder. So delay in motor, language, and social functions is associated with psychosis and has been found to be associated more with psychosis, and bipolar disorder with psychotic features. So again, when we're looking at this kind of things, developmental aspects, psychosis or schizophrenia is at the tops with all these kinds of things. And to a lesser extent, these things are found in bipolar disorders. Individuals with early onset psychotic bipolar disorder and schizophrenia exhibited comparable impairments in cognition and early adjustment. So not bipolar and schizophrenia, but if you have the psychotic component, then again it comes very close to schizophrenia. Premorbid cognitive dysfunctions appear to be present in a specific subgroup. We have not been able to identify exactly which subgroup, but people feel that if you're able to, then you would have a kind of a specifier or a subgroup which will need to be addressed a little bit differently, rather than just exposing them to the standard treatments that we have. And this actually represent a transdiagnostic phenomenon across entities of borderline of bipolar disorder and schizophrenia, and delineate a cognitive subtype which is also there in unaffected relatives. So again, it is a spectrum. So we will have something in the relatives which is minimum. Then we can have a specific subgroup in bipolar disorders, more so in bipolar psychotic and schizophrenia. Um, so developmentally, bipolar disorder is also linked to ADHD, ASD, and schizophrenia because there are common disruptions in brain development and all these factors that we know of exposures to adverse events during pregnancy like infections, maternal lifestyle, unhealthy diet, maternal addiction, stress exposure during pregnancy, obstetric complications, and early life trauma. Though perinatal infections have little evidence, but in vitro exposure to medications, illicit drugs, or smoking is more associated. Other risk factors include older paternal age, which is definitely there as one of the high risk factors in etiology of autism spectrum disorders. Perinatal exposure to oxytocin, which probably impairs the feedback cycle and leads to impairments in social cognition, and disrupted endocrinological programming of the HPA axis through early exposure. We'll come to that a little bit later on. Right. Now, with all these things in background, as it happens in many patients, is that they will come and tell us that there has been some stress, and after this, the person is like this. But what does actually the stress do? It kind of precipitates something, but not actually cause it. So it is basically the perceived threat, perceived stress in terms of threat, helplessness, and vigilance. That is how the brain understands it. There is going to be a set of physiological responses, individual variations, as we have seen, and behavioral responses. Now, till a certain point, which is allostasis, means the systems are getting a little bit taxed, the brain is working a little bit more, but it is trying to maintain a homeostasis. But if the allostatic load increases, the adaptation fails and a person ends up with something like bipolar disorder. So stresses could be anything in the environment, major life events. So some people do not have adverse life events, but they come and say that after my promotion, this thing happened. And of course, early childhood experiences like trauma and abuse. So this allostasis is not only something which is just a term, but it happens at different levels, which could be neuroendocrine and metabolic. So basically hypothalamus and the areas that govern or control the hypothalamic functioning at a cellular level in terms of mitochondria, because mitochondria deal with energy function. So if they're overworking, they can fail also. At cells of each and every part of the body and in each and every cell in terms of telomere shortening, epigenetic dysregulation, and in all organ systems. So what I'm trying to say here is that with the stress, an individual can develop bipolar disorder, but can also develop a lot of other things because there is something happening in all the cells, including the neurons, in each and every system. So what is this early life stress leading to? It leads to something called as HPA sensitization, means the hypothalamo-pituitary axis becomes more sensitive to stress. So it fires quickly, it fires longer, it doesn't come back to normal. So there is always an increase in the circulating cortisols. Circulating cortisols have got both cellular effects, cytoplasmic effects, as well as nuclear effects. And then again, because of nuclear effects, there is a change in it induces an epigenetic change, and this cycle continues. Even the sympathetic overactivity of high catecholamine levels can lead to sensitization of that symptom. So persistent elevation of heart rate, blood pressure, and things like that. Polymorphisms in the serotonin receptor 5-HTT-LPR, that is known by another name which we saw, SCALA6, that one. Okay, the shorter arm has a higher risk because that transporter is not working very well, and that causes a sensitization of the serotonin systems also. Oxytocin is hampered, as we mentioned earlier, with regards to stress. The same thing happens here. And overall, there is an immune modulation. So there is a dysregulation of the immune system because these glucocorticoids are not functioning well. The signaling is impaired. And inflammation will activate the HPA axis by itself because of this, and there is going to be glucocorticoid resistance. All these things lead to a problem with developing brain microstructure and connectivity. It's not only that the cells are not functioning well or the regions are not functioning well, but how in an interconnected manner they work is also impaired. specifically associated with corpus callosal left anterior cingulate, right occipital left temporal, and right medial frontal gyrus abnormalities. Widespread, but again, the common underlying cognitive development in terms of intelligence, emotional regulation, social cognition, and mentalization get impaired. And it manifests as problems in executive functioning, working memory, and the verbal IQ. Now, what are the clinical and psychopathological dimensions of something like this? So maternal stress, prenatal medical illnesses, and obstetric complications will contribute to this thing. There is also a genetic environment interaction again, but the bottom line is this neuroinflammation, which we'll see a little bit later on. And the most important thing is kindling. With all these changes which we saw here, all this sensitization, HPA, sympathetic, serotonin, oxytocin, neuroinflammation, we also have something called as kindling. The amygdala become hypersensitive. So they react fast to threatening stimuli. There is going to be an abnormal threat perception and so on, and then the disorder will develop. Another aspect of the disorder is something called as neuroprogression. Means one, the disorder evolves because of, as we now believe, because of various neurodevelopmental factors, but it also progresses. So it is not that I have had my first episode of mania and it gets better and that's the end. I have had my first episode of depression, there was a period of normalcy, then a manic episode, and then it ends. There is a progression, and this progression is not only symptomatic, but depends on, again, a number of factors, including at the center of it all, neuroinflammation, oxidative stress, mitochondrial dysfunction, impaired HPA axis that we saw. So what we are trying to look at here is that each episode contributes to all these things cyclically. First episode of mania, for example, it starts with all the neurodevelopment that we talked about. But when that episode happens, there are still changes going on. It adds to the neuroinflammation, it adds to immune alteration, it adds to growth factor metabolism issues, it further sensitizes the HPA axis, it induces more mitochondrial dysfunction and oxidative stress, and is associated with structural changes. So the amygdala becomes still more kindled. So after a certain point in time, what happens is that even without any obvious stressors, as we see, even without an additional allostatic load, because there is a structural change, because this is already there, the amygdala keeps kindling, and we have got episodes for which nobody has any answer in the external world. So this is again a diagram of what happens in neuroinflammation. Again, if we see the areas are frontal cortex is always going to be impaired, implicated in the disorder. We have got anterior singular cortex. We have got the CSF measurements of interleukins and other inflammatory, both pro and anti-inflammatory markers. We have amygdala and we have hippocampus. Amygdala and hippocampus because both of them serve as we can say reservoirs of emotionally laden memories, emotional experiences, and when they are brought here to the frontal cortex, they are not interpreted well, not analyzed well, and they can sort of lead to the development of symptoms, as we know. So after the onset of a disorder, as I said, this neuroinflammation can become self-sustaining and may not need any continuous exposure to etiologies, may result in neurodegeneration of brain regions, right? And constant neuroprogression over time reaches an irreversible level. So if I see a patient now, first episode of mania, some amount of neuroinflammation is on. If it happens again and again, by the time, let's say he comes to you, you are the 5th or the 10th psychiatrist, 10, 15 years have gone by, there is a totally different kind of brain function that's happening, and probably the patient is going on for what we would classically call it as resistance, not responding to treatments. You try this, try that, nothing. We call them burnt out, which is metaphorical because there is inflammation inside, so it is actually equivalent to burning out. But what we have found is that the source of this inflammation, in all these areas, is basically the glial cells. We have always looked at neurons with pride that, oh, these neurons are functioning fine and all, but basically neurons are somewhat kind of pampered because they are in a very good cushiony kind of an environment. All their needs are taken care of. There's a lot of support should anything go wrong, and that is done by the glia. Now this glia are kind of watchmen, nannies, support staff, grooming staff, feeding stuff of the neurons. And one of the important things they do is maintain the immunomodulation of the entire neural ambience. So when glia start producing abnormal inflammatory factors, then all this kind of neuroinflammation gets sustained and it keeps going on and on. Another thing is dysregulated neurotransmission in terms of dopamine, excessive glutamate, excessive levels of serotonin and norepinephrine, which can keep on stressing the neuroinflammation, because when there is an excessive turnover of chemicals of this nature in the brain, there's going to be more metabolism, there's going to be more need to eliminate the metabolites, more need to produce these things, which is a load on the neuronal cells, the glia and the mitochondria in them, and it leads to the development of free radicals. And if these free radicals are accumulating more than they are getting disposed, then they can be neurotoxic. So that is what they're saying. Excessive dopamine exacerbates oxidative stress. Enhanced level of glutamate in ACC and prefrontal cortex almost does the same thing. And abnormal levels of serotonin and norepinephrine could disrupt, in addition, appetite, circadian rhythms, learning, memory, so on and so forth. So the another way of looking at it, and more people are looking at this, is the mitochondrial dysfunction. Very simple. You are more active, you will need more resources, you will need more energy, you will produce more metabolites, they will need to be metabolized, removed, so on and so forth, brought back into circulation. So again, more resources are there. The mitochondria are energy powerhouses of the cell, and they will allot the energy, but if they're getting taxed, they themselves can undergo a lot of damage. Okay. So mitochondrial dysfunction will accelerate cellular damage, synaptic dysfunction, and impair neurogenesis. So one of the newest theories for bipolar disorders is mitochondrial dysfunction. Where does it happen? In all cells. Who is guiding it? Glial cells. And oxidative stress, so activation of immune inflammation and autoimmune pathways, will all of these things lead to an oxidative stress. Basically, it means that there are free radicals that are generated in these metabolic processes, which accumulate, which are not cleared out, and this will lead to lower BDNF levels. The third approach is BDNF. People are looking at BDNF because it seems to be a robust marker for the depressive phase, the manic phase, and the continuous phase of bipolar disorder. So if it is there, low levels, then normal, then people feel that it is definitely a disorder in progress. Altered growth factor metabolism, as I mentioned before, BDNF, so we'll not get into that again. The HPA axis, as we know, gets sensitized. That is a neurodevelopmental finding that we know, but also with more episodes, it gets more and more sensitized. So that is also neuroprogressive. It has been implicated in the pathophysiology of neuroinflammation, and the rate of impairment is associated with the severity of symptoms. So more impaired HPA, more severe symptoms. And what is also important is that the genetics of HPA activity, means where various regions that are involved in the hypothalamus, pituitary, adrenal axis, as well as their cells, how active their cells are, and what tropic factors or what release factors or what active hormones they are producing, is all under genetic control. So the expression of genes associated with HPA axis related function is changed during BD. So it is not only at a level which is just a feedback, but even at a basic genetic level, the HPA axis activity is changed. And some of this is also found in unaffected family members of patients. So again, we think that we are on a spectrum of impaired HPA axis activity and sensitization. So what people have found is that in depressed polarity and manic polarity, there doesn't seem to be at a genetic level much of a difference when it comes to HPA. So again, like BDNF, HPA is also impaired in both depressed and the manic phase. Another player which we are now again looking at is, again, it's a totally different system, which is called as the gut-brain axis. You do not need to look at all the things in the diagram, but well, whatever at first glance you can pick up is there is an HPA axis involvement here, correct? There is autoimmune, so immune dysfunction is there, correct? Okay. If you look at here, somebody will pick up GABA here somewhere 5-HT. So we have something called as a brain equivalent in our gut, which does similar things, except make us talk or motor functions like walking, but it does almost similarly. So we have got kind of two nervous systems intercommunicated with each other. So what is happening here is going to have an effect on brain function. So the type of gut bacteria, so you have got short chain fatty acids which are released by certain bacteria, certain commensals. When the bacterial population in the gut changes, that also has got an impact on neuroinflammation. And now we know that neuroinflammatory cytokines that are released at, let's say, gut level can also travel to the brain. They're permeable through the blood-brain barrier. Whatever immune neuroinflammation happens and all those chemicals, chemokines are released, can cross the blood-brain barrier and come into the gut via the bloodstream. So it's like a free exchange of stuff, and the processes involving both will be similar. So if something starts here, that is what we are trying to understand. How is gut bacterial population important in any psychiatric disorder? Gut bacterial population has its own genetics, its own epigenetics, its own developmental trajectory. And that is how it has got an impact on the development of bipolar disorder also. When we look at phenotypes, this is typically what DSM-5 will tell us. Okay, so that is, I think Sir is going to talk a bit about it. I'm not going to get into that. But what are we going to look now is when a disorder happens, how can we look at what is happening? All that is there is quite theoretical, quite research-based, good to know, maybe not very ideal to know in a day-to-day setting, but there is something called as functional neuroimaging fMRI studies, which have given us a lot of wealth of information as to what is happening. So basically at 3 points, the first point is what happens to the emotional processing circuit. So we'll just focus on this star that is amygdala, and we'll focus on this star which is ventrolateral prefrontal cortex. Now if you look, there is like a bang. This star amygdala is hypersensitized. So it produces a lot of fear-related emotions, and along with the hippocampus, fear-related memories, which will go to the ventrolateral PFC for processing. This is not processing well, so it will allow these things to go into the prefrontal cortex, leads to the cognition or cognitive impairments of bipolar disorder. And all these other things, there is a problem in the pregenual anterior cortex, which is not working well. Pregenuals will come here somewhere, it's shown here. Okay. So two main important things. These are seen repeatedly in functional scans. Another group of findings is what happens to the reward pathways. Again, what happens is that there are 3 explosions here. Ventral striatum, which is a part of the reward area, so high dopaminergic activity. Orbitofrontal cortex is also working overtime, so it allows all this information to pass. Ventrolateral PFC, especially when the processing is fast, it actually kind of gives a lot of permissiveness for how would I say, there's a positive stimulus, so it is going to give a lot of input for the brain to produce changes in line with that. So if ventral striatum finds something interesting, high dopaminergic state, this is kind of going to the input is going to the orbitofrontal cortex. It allows it to go to the ventrolateral prefrontal cortex, and when it allows it to move ahead, so a person has overactivity, overwork, overthink, overtalk, overspend, and things like that. And what is also important now is that when the brain is, let's say, not doing all these things, so resting state, and that is where people look at how various regions are connected in terms of networks like default mode network and things like that. So these are the regions of interest. We are not going into details, but what I'm trying to say is the more we have better technology to image the brain at various points in time, in a manic brain, in a depressed brain, in a resting state brain, we are coming up with findings which are kind of, how would I put it, happening again and again. They are robust findings happening in definitely subgroups of populations, not happening in all. That is a drawback. So we need to work on this, and we'll come up with some things. So newer imaging areas are mood state specific abnormalities. These are more general. Different bipolar subtypes, if you can image in youth and adults at risk. So if you're able to, we can give strong biomarkers for this, imaging biomarkers. This can be done. Of course, none of this is a robust biomarker, so all of us will be doing it or not, but stronger than any others. Sleep is also getting affected. There are specific changes in sleep patterns in euthymic states, manic and depressive states. So another thing that we commonly find in our patients is sleep cycle or circadian rhythm abnormalities with melatonin also. And what is most important is this whole list. The only thing about this list is that on the extreme left, these are the genes that are involved in sleep and circadian rhythms. And on the extreme right is the disorder, which also presents with a similar genetic makeup. So most of these sleep related genes and circadian rhythm genes are also getting impaired in this disorder. So there is a kind of a genetic commonality in circadian rhythm function and the involvement and of the circadian rhythms in sleep disorders and mood disorders. So it's not that depression has or mania has some sleep abnormalities. No, it's not because of mania. Genetics is common. When we see patients over a period of time, it is not only neuroprogression that I mentioned before, but there's also something called a somatoprogression. Means along with the brain, there is also progression of bodily problems. Chronic inflammatory diseases like cancer, obesity, diabetes, and cardiovascular disease, because again, there is an inflammatory state, oxidative and nitrosative stress going on, impaired HPA axis activity. Metabolic dysfunction is all same. And as I mentioned, inflammatory factors migrate to and fro the brain to systemic circulation because BBB, that's a blood-brain barrier, is always leaky to such things. Right? So even metabolic syndrome. So initially, people say, and people still say that with atypical antipsychotics, patients gain weight, and it was not so much with the older antipsychotics. The reason is that if you have something like this going on, patients are already predisposed, and an atypical given can, kind of act as a trigger, and then cause weight gain, can cause insulin resistance, can lead to hypertriglyceridemia, and the metabolic syndrome. So people are predisposed. It doesn't happen overnight. And it is also associated with premature aging. So when things are happening fast, neuroinflammation going on and on, the aging is faster because everything gets worked on continuously. So along with bipolar, neuroinflammation, we have got multiple somatic problems coming up, and basically it also leads to something called as telomere shortening. It affects the chromosomal metabolism also, and there is a shorter life expectancy comparable to schizophrenia. So a disorder which starts so early, has a neurodevelopmental phase, has a progressive phase, has a neurodegenerative phase, has a somatoprogressive phase, is going to be associated with premature aging also. So biomarkers, what people are looking at, we need biomarkers. We need things which will help us to pick it up early. And so people are working on HPA related because it is strictly tied. But what are we going to look at exactly? Whether it is cortisol, we have looked at cortisol for ages, but you will not find really something which is groundbreaking. But yes, if you can look at the genetics, we can. Another one is BDNF, as I said. BDNF is also one which people are looking at, but the problem is these things don't happen in all patients. So we need to be a little bit more robust in our findings. Oxidative stress markers. Okay. A bit difficult because there are a lot of other things that are involved in oxidative stress. So whether this is going to be specific for this or something else, that we need to be more sure. When it comes to therapeutics, actually we have learned. So this is the spectrum of polarity. This is a kind of a relative efficacy in mania and depression prevention. This is for depression. This is for mania. We are not going to into these details, but what we have understood and what we continue understanding with in terms of etiopathogenesis of bipolar disorders is regarding lithium. No other drug has contributed to the understanding of the disorder as much as lithium has done for bipolar mood disorders. So effects on GSK3 beta, BDNF, changes in gene expression of glutamate, cell degradation. It has got neuroprotective effect and anti-apoptotic effect. We now know about genetics. I have not put those pictures here, but even lithium genetics is pretty much to be understood, because there is a certain overlap between how lithium is going to be handled by the body, how a person is going to respond to lithium, and a lot of other things. So a lot of genes related to lithium response were not involved in etiology of bipolar disorders, but what 20 were gave us a lot of understanding. We'll not get into details, but lithium has basically effects on one, GSK3 beta. Important GSK3 beta is that it is, if this is inhibited, it is DNA protective. It regulates the circadian clock well. It is BDNF promoter. So all good things. That is the first effect. Second effect is inositol phosphate. If inositol phosphate keeps on accumulating, it is neurotoxic. So lithium inhibits that. Good effect. Third effect is basically on all these neurotransmitters. Okay. So the second messengers related to dopamine, GABA, they are inhibited. So their downstream effects are kind of curtailed, and it has got an inhibitory effect on all neurotransmitters, and synergistic for GABA. So there is a quietening of the cell. This is what lithium does. And this is what we know about lithium. So it has got wide variety of actions, and not only in terms of stabilization of the cell, but downstream effects on circadian rhythms, effect on neuroinflammation, effects on BDNF and growth factors, and anti-apoptotic effects. Another one which we are looking at right now is Endoxyfen, which is a PKC inhibitor. Phosphokinase C is a group of proteins, enzymes, which basically are involved in cell signaling of glutamate, norepinephrine, and serotonin. Okay, so lithium and valproate also reduce PKC activity, but endoxyfen is more specific for PKC, and it gives us another insight into what is probably happening in bipolar disorder. This actually gives us the regions where the drugs that we use act and what they do. Self-explanatory. If we look at the lateral aspect, dorsolateral prefrontal cortex works better, stimulated by lamotrigine. Here carbamazepine, now we want them to work a little bit more stable, because that's the emotional information that is coming from lower centers. So the areas, the important ones, do get affected in a better way by using psychotropics as we use them. The newer target systems, we know glutamate, so we have ketamine, esketamine already in use. Opioid system is another one which has got mood related effects. I would not say mood stabilization effects, but mood related effects. Circadian rhythms modulating agents are in use. What we are going to look at is inflammation and oxidative stress. Omega-3 fatty acids, NSC, minocycline are there, but not really robust effects. Insulin signaling is one, because insulin is not only related to glucose metabolism, but it has got, again, a lot of effects on the neurons, learning, memory, and so on and so forth, and gut-brain axis. So these are what we are looking at right now in terms of newer drugs and newer targets. When it comes to non-invasive brain stimulation, we have had lots and lots of things about ECTs. It does work, but ECTs, again, like lithium, too many effects, we don't know whether it's working. And the current trend is with non-invasive brain stimulation available with hardly any side effects, whether they can be used. So we have studies on RTMS, DTMS is deep TMS with an H1 coil. We have transcranial direct current stimulation, but we are still uncertain about what are the ideal parameters of use. There are a lot of advantages in terms of hardly any side effects, no pharmacological interactions. Best use when there is as add-ons, but as it stands, there are no guidelines and there are no ideal parameters. So it is going to be, if I'm using it, it's going to be trial and error and see what works. Physical activity, yes, it does have an effect in terms of cognitive health benefits, increase in endogenous opiates, indolamines, epigenetic differentiation over a period of time, lowering of inflammatory markers. Now, these effects are more robust when it's unipolar major depression. Similar effects are seen, but not as strong or as robust as in unipolar major depressive disorder. When we integrate all these things, we come to something called as RDOC, which is another way of looking at any disorder in psychiatry at all possible levels, right from genetic up to the symptom presentation level. So yes, with regards to bipolar, we looked at genetics and epigenetics. Yes, we looked at signaling. Yes, we looked at plasma membrane. We looked at receptors and all those things. Yes, we looked at glia. Yes, we looked at microstructural synapses. Yes, we looked at a lot of studies. We looked at all this volume loss and things like that. We looked at the symptoms, sub-symptoms, and sub-clinical presentations. Yes, we did look at all of these things. But there is a group of studies which have been put forward by this group called as Bipolar and Schizophrenia Network for Intermediate Phenotypes, called as the BSNP. Not going into details, but they are trying to follow the RDOC framework, and they have come up with a lot of interesting findings. There are a lot of similarities when you look at patients who present with bipolar, schizoaffective, and schizophrenia. These three are just clinical phenotypes, but there are underlying commonalities and differences in these patients as well as in this the family members of these patients as spectrum. Interesting, it's not one study, it's a group of papers. What is going to happen now, what we are looking at is what we need to be doing as clinicians is deep phenotyping. Basically, it means that along with the mood disorder phenotypes that are presented to us, we need to look at a lot of things. We need to look at genetic data if available, developmental aspects, we can get something. We need to look at the overall physical functioning, family history, drug responses, the nature of the problem, of course. This is called as deep phenotyping, means everything that is presenting in that patient is a phenotype, not only the mood, the cognition, the sleep, and the appetite, lot of things, which is called as deep phenotyping. So a lot of information, including information that we obtain from imaging, blood studies, and so forth. All this becomes big data, a lot of data regarding individual patient. The idea is that guidelines are fine, but the bottom line of using any guideline is that it has to be individualized, then only it works well. Lithium might work well for me. Sodium valproate may not work for me at all. I might have a lot of side effects. But if this is known, this becomes a bit of information which is big data. You can have all my data. We will have artificial intelligence systems which are not science fiction, which are programmed by us, programmed by our understanding of disorders, and we can arrive at a more personalized kind of treatment, including the treatment of bipolar disorders. Thank you so much for your time and patience. I hand over the proceedings to the organizers. Thank you so much.
That was a loaded lecture of information by Dr. Malaidave. Well, he got us know that for bipolar disorders, we don't not even got to think with our brains, but it is literally a gut feeling. Okay. Anyways, we move on to the next speaker now, and then maybe we'll take all the questions at the end. Dr. M.S. Reddy. Well, many of you all must already be knowing him. He has spoken at multiple forums in the past, and we are very fortunate to have him speaking to us on this hyperactive BPS this year, where we are conducting a lot of updates and CMEs. So Dr. M.S. Reddy is a part of the International Society of Bipolar Disorders. He's at Hyderabad. He's also a director of the Asha Bipolar Clinic at the prestigious Asha hospitals at Hyderabad. And is someone who's just working purely in the field of bipolar disorders. So I'm sure we have a lot that we want to hear from him. Both our speakers today gave me told to introduce them very briefly so that they could just start with the lecture straight away. So straight away to you, Dr. Reddy.
Thank you. Thank you very much, Dr. Rashmin, for those kind words. How much time I have?
So there is 30 to 45 minutes. Sir.
30 minutes. Okay. Thank you so much. And that was a fantastic lecture by Dr. Malaidave. It's a very impressive. It really has taken us through the entire journey of starting from the neurodevelopmental, perinatal to neuroprogression, the entire thing, like whether it is the gene expression or the inflammatory, and then starting finally to the mechanism of action of lithium and one of the new drugs, Endoxyfen, the whole lot. I was actually looking at the reference, what Dr. Malay was looking at, Road to Novel Therapeutics 2021, where a lot of information has come. Throughout the lecture, I was wondering, there's so much is happening in the last few decades about the neurobiology, especially with the functional imaging, genomic studies, and the whole lot. Is it getting translated into the therapeutics? Where are we in the management of bipolar disorder? Lithium, 7 decades, even today, lithium is the gold standard. We talk about lithium. So after the fascinating lecture by Malay, which who took us through the entire the brain mapping, I am basically a clinician. I have a presentation which is completely related to the day-to-day management of only mania. I'm not going to talk about much about bipolar depression. All of you know that bipolar depression management has become a landmine now. It's the most controversial topic it has become. So I'm limiting myself to the management of acute mania, maybe a few slides adding to the prophylaxis, but mostly limiting to mania, and also from the strictly clinical sense. And I will also try to finish my talk as early as possible so that we can have a little bit more of a discussion part of it when it comes to that. What are the challenges? After all, now as Dr. Malay has told, which start from the perinatal period, coming to the adolescence, where almost about 40 to 50% of the patients with bipolar disorder, the first episode is below the age of 20. A patient had an episode of acute mania. He is in your clinic. And how do you manage? How do you go about it? Broadly, when I talk about mania, I said that primary mania, which generally we don't use the term, bipolar disorder, mean. When I see a patient with mania, I look at this triad. The ACE, activity, cognition, emotion. Which of this? It's usually the combination of hyperactivity, emotionally the elation, expansive or irritable, cognition, the kind of grandiosity of what he has. So mainly based on which component of it is high in this. Suppose somebody has got a severe hyperactivity. You need to contain him. You need to sedate him. You need to give him a sort of a little bit of a chemical, straitjacketing, which is the immediate thing. Suppose it's more of an elated mode. All right, I can wait for some time. Suppose it's extremely irritable. Irritable hyperactivity sometimes can be very, very problematic, especially leading to the violence and then some of the socially disruptive activities, where again, there's an emergency to contain the cognitive component of it, the grandiose component of it. Here again, suppose somebody says that I'm going to contest next elections and then replace Narendra Modi as the Prime Minister. Or somebody says that, Dr. Reddy, I'm going to produce a movie. I already have given an advertisement and I'm going to recruit heroes and heroines, and then and then the next week I'm going to spend a few lakhs on that. All these things, the urgency of it, the which drug you select, which combination you select. I'm going to run through the list of various separate aspects of mania, but I'm not saying that each separate component, what I'm talking about here, has got a separate new drug, but it's only a mixture of drugs, a combination of drugs, or monotherapy, or sometimes dose titrations, selection of the drugs, and then the duration, how long you can wait. These are the things which we are going to see. That I'll just run through that, and then maybe in the end, if you have time, we can discuss the individual components. The bipolar disorder, when you come to that, the episodic, the recovery is the rule. I keep repeating it any number of times. Recovery is the rule, recurrence is the rule. If it is predominantly manic, then the kind of drug what you choose may be slightly different, if it is predominantly depressive, because quite a few drugs like risperidone, where it is haloperidol, primarily like the typical antipsychotics, virtually I am not using. I don't think any of us are using all. It's mostly second generation. Even then, some of the drugs have depressogenic effect. So I keep that in mind. Acuity of onset. You all of you know, clinicians, in some cases, mania develops in just a day or 2 days. Some days, some patients, it takes about a week to build up. What is the severity? How frequent is the number of episodes? Seasonality. Here, do we go for a little bit? I'm not talking about strictly prophylaxis during that period. As you all know, that postpartum period is the one period where there's almost certainly there is going to be a recurrence. Even though there is no immediate manic episode, can we start thinking about starting a molecule to sort of prevent or early management of the mania, which is impending. Here, Dr. Malaidave was talking about Kindling hypothesis, which was actually now like it's almost like a Robert Post who talked about almost about 3-4 decades back. The whole lot of anti-epileptic drugs which we are using now, it is based on the Kindling hypothesis. We can discuss later. I have a little bit of few reservations on this Kindling hypothesis. Broadly, I'll say one thing. And also there is neurobiological progression, molecular changes, neurobiological scars, for a period of time, oxidative stress which develops, and initially there may be requirement of a major stress. Later, there is no requirement of any precipitating or stressful factor, and there can be, it's almost like an automatically the episodes developing. These are all the theories we keep hearing. This is some of these points what I discuss, what I talk about is very much open for discussion. If you ask me, the first episode of mania, how I treat, tentatively I put as 10th episode, 6th or 7th episode, how I treat, acute manic episode. I know some of you may not agree with me, but I say that it's almost the same. Quite a few patients, it's almost the same. And the recovery, the improvement is also, I see that a lot of patients, even in the 8th or 9th or 10th episode, they do recover. Symptomatic recovery I'm talking about, they do recover. With psychosis, without psychosis, do we make a clear-cut differentiation? Mania with psychosis, mania without psychosis. Generally, we talk about giving an antipsychotic. Anyway, we give antipsychotic for all the patients with mania. Is this pattern? Not like, does it depend? Mostly we talk, when we talk about the prophylaxis, we talk about this pattern, not for the management of acute mania. Today, I am broadly limiting myself to management of acute mania only, except last 2-3 slides where I talk a little bit about prophylaxis when I talk about lithium. Right, coming to the secondary mania, steroids, especially now with the post-COVID, this rampant use of steroids. I've been seeing quite a few cases where steroid-induced short, brief manic episodes, traumatic brain injury, frontal lobes, substance-induced. Most of these episodes we do treat in almost, we will not use lithium, but we do use antipsychotics, broadly antipsychotics, but the duration may be shorter period compared to the, in case of now like a bipolar disorder. That's the only difference here. But depending on the age group and all that, you know, like decide the dosages. Comorbidity. This is one of the problems. Mania with anxiety disorders, generalized anxiety disorder, panic disorder, OCD. I don't know how to manage. I'm really at a loss to manage. A lot of times people do talk about cognitive therapy for this anxiety disorder, OCD, but I don't know. The only drug I know is an SSRI. Then how do I know, I can think about SSRI in a patient with mania? Fortunately, quite a few occasions during the manic episode, OCD symptoms subside. If we have to treat the comorbidity, it's always very critical. Especially substance abuse, again, it complicates the clinical picture of mania. You can give some of the drugs like naltrexone, baclofen, you can give along with whatever the drugs you are using. You use the so-called mood stabilizers. Here, again, one of these terms of mood stabilization, I have a lot of reservations and use it also usually most I talk about prophylactic drugs, because this mood stabilizer, this is one term which I think has really complicated the management of bipolar disorder. Then physical comorbidities. Now we all know that when there's associated physical coma, especially when it comes to lithium and then renal functions, the dose titrations are sometimes not using, hypothyroidism again. This is all these conditions we have to keep in mind and choose the particular drug, whether you're using lithium or one of the anti-epileptic drugs or one of the antipsychotics among the antipsychotic group, which drug you're preferring. You all know that. That's why I'm not going to the individual details like whether you prefer risperidone or olanzapine or quetiapine. But really, I don't see much of a difference. We are not using much of asinapine. And then ziprasidone is also not really much used. So we have very limited drugs when it comes to the second generation antipsychotics, aripiprazole, and these drugs, nothing more than that. Which drug to use, and then what exactly is the goal there when you're using the short-term goal. We're all talking about short-term goal when we talk about the management of acute mania. And again, different populations, pediatric populations. One of the recent papers says that in adolescent age group, risperidone is much better than lithium in the management. Geriatric, it all depends on number of episodes. Or the first episode, as I told, some of these things we can discuss later. Pregnancy and lactation. Suppose somebody develops an acute mania. What is your drug of choice in pregnancy? What is your drug of choice in the postpartum period of lactation? Obviously, we don't start lithium. We don't start any of the anti-epileptic drugs. Then what is our choice? Like, are you going to start olanzapine? These are the things which we have. The antidepressant-induced mania, I put it separately because even though DSM-5 puts into the bipolar disorder, there are a few occasions where just decreasing the doses of itself takes care of it. That again is a controversial area. Maybe we can discuss. Unipolar mania is a new concept. Here I'll tell you, all of us, almost every one of us, when we started learning about bipolar disorders in our postgraduate days, we all had that doubt. Some of the patients I see only mania, I don't see depression. Why should it be bipolar? Then we were all told that there are depressive episodes, there would have been depressive episodes, or there may be depressive episodes, so there's nothing like unipolar mania. But this is a concept which is again coming back, especially Jules Hang's one of the recent papers in 2018, he talks about unipolar mania and say that this has to be established as a separate entity. I put mixed episodes last because tell you frankly, I don't know how to deal with this mixed episodes. Most of the time I treat it as acute mania only and nothing more than that. So what are all the challenges? Here, recovery is the goal. Recovery is a fact. Every episode in bipolar disorder has to recover. Symptomatic, there's no doubt about it, but whether every patient has a functional recovery, right? There are a lot of questions and a lot of people don't agree that there's going to be functional recovery in patients with bipolar disorder. But I largely look at, if you can get symptomatic recovery in a patient, that will be the first goal. And then that is the goal where slowly we can guide them, nudge him to the functional recovery. There could be a lot of problems. And then whenever I talk about the management of mania, mostly I stick to the pharmacological. A lot of times people ask me, why are they sticking only to pharmacotherapy? And then what about the psychosocial treatment? Psychosocial treatment, something like CBT has been talked about in every other psychiatric condition. But I think generally in mania, people don't talk about CBT in mania. CBT in depression, CBT in anxiety, CBT in schizophrenia. Dementia they talk about, and CBT in mania generally people don't talk about. CanMat 2018 categorically says that among the psychological therapies, level 1 evidence is for psychoeducation. When we talk about psychosocial treatment, the first thing which comes to our mind is IPSRT, interpersonal socialism therapy. But CanMat has clearly told that as in today, it's only got level 3 evidence. The one evidence is psychoeducation. I think all of us do this. We don't have to give separately psychoeducation. We talk to the patient, we explain to the patient, we discuss with the patient relatives what the current status, what the next step. We do that. So automatically we do that. This is in a routine as a basic thing of a medical doctor, we do this. So I say that we don't have to do anything extra here other than giving them a clear-cut idea about what the bipolar disorder currently and then the future. Beyond that, doesn't seem to be, especially in the management of mania. Yes. Dr. Malay Dave, they talk about lithium, and then lithium somehow how the mechanism of action of lithium, whether it is GSK3 and then protease kinase C inhibition, and then inositol, and then multiple systems it works. But after 7 decades, still we do not know what is the mechanism of action of lithium. It doesn't mean that we know the action of other drugs, but at least other drugs like risperidone, quetiapine, we know that predominantly dopaminergic system. But lithium we still do not know. And whenever anybody talks about bipolar disorder, especially mania, lithium is the gold standard. I don't think there's any kind of a controversy, a discussion about it. I have put a but there. Lithium is the gold standard, but I'll come to it a bit later. We do talk about lithium. All of us talk about lithium. But are we using it? Polypharmacy. When we talk about the management of bipolar disorder, one of my major complaints is that polypharmacy, the so-called rational polypharmacy, has become an accepted norm from day one. Unfortunately, we don't do it in any other psychiatric condition. We don't do it for schizophrenia. We don't do it for depression. We don't do it for anxiety disorders, whether it is autistic spectrum disorders and other geriatric disorders, dementia. We don't start polypharmacy from day one. Unfortunately, for bipolar disorder, it has almost become an accepted norm from day one. Polypharmacy. Polypharmacy has its own, the adverse events of polypharmacy is so much, because one of the problems you see is that, here I'll take a minute in describing this. All of us know that management of an episode, especially in the bipolar disorder, acute episode management, second is continuation phase, third is maintenance phase. Maintenance phase, we look at prophylaxis and then prevention of the next episode. But the acute episode management, we have two phases. One is acute phase, where you bring down remission, what we call it as, bring down the YMRS to less than 8. After 3 weeks or 4 weeks, you treated a patient, YMRS is less than 8. Then, do you stop the medication? No, I'm not talking about prophylaxis. No, even for the single episode also, we are all told, we practice that there's a kind of a continuation phase, which we were all thinking that remission to recovery phase, which is about, let's say about 8 to 12 weeks. This continuation phase, the management of this, is it peculiar to only psychiatry and then psychological medicine and also only bipolar disorders? We all can discuss later. One of the main problems why I wanted to talk about this is, all of you have treated patients with mania in your inpatient setup. Let's say one manic excitement, you're treated as inpatient, you're giving him lithium, you're giving him antipsychotic, let's say risperidone, and along with lithium 800 milligrams and risperidone about 8 or 12 milligrams, plus you are given some either clonazepam or zolpidem for sleep. When he's in the hospital, he needed this combination of drugs. Even with that, once in a while he had a sleep disturbance. Still the high manic symptoms, psychotic symptoms. You discharge him, he goes out. He doesn't have manic symptoms. But then one of the common complaints in the continuation phase is that they come back with saying that, doctor, I'm feeling too much sedated. I'm sleeping day and night, doctor, I'm too drowsy. This is what I talk about. This is not a serious side effect, but this is a significant side effect. Patients do have to go back to work, whether it is a housewife, whether it is job or business, they have to go back to work. They can't be sitting at home for 3 months or 4 months during our continuation phase. If they is too drowsy, his functioning is going to be impaired. If he has tremors, if he has got the mind like an akathisia or rigidity, like in a subclinical rigidity, all these are side effects. Your clinical picture has come back to normal, but because of these side effects, every time when he comes for a follow-up, he demands that you do something with the medication so that his side effects are reduced. Standard thing is we start reducing the dose, but every time we reduce the dose, we are a little bit shaky that at what point of time this is going to be the optimally minimum dose, or is going to have again relapse of it. This continuation phase is very, very tricky. You don't do this in diabetes. You don't do this in hypertension. Once he's stabilized unless he changes his diet or some other activities. Only here, the medication regimen which you have prescribed and stabilized the patient, once he goes out, the next 2-3 months, it's a continuous phase of stepping down. That is where now like lithium scores there because it's a non-sedative drug, no EPS, but the problem with lithium is it's a tremors. So these are the adverse events. Why I'm very specifically talking about this is that you made the patient asymptomatic. YMRS is less than 8. But for this symptomatic recovery to migrate to functional recovery, all these side effects, which are disturbing side effects, or significant side effects, socially problematic side effects have to disappear. Whether that is this adverse event is one of the factors which is impeding this. There is one very, very influential paper from the Barcelona group, Edward Vieta, where he clearly says that 2 important factors, which is now like roadblock from symptomatic function. One is the cognitive dysfunction. Second is that adverse event profile, which is because of our drugs. That is where I say that polypharmacy, what we use, initially it may help us, but later it is creating problems, especially in getting the patient back to functional recovery, where we have to be extremely careful. I know, I think some of you must have been attended Rashmin talk also. Even, like he was telling that even the textbooks talk about it, we polypharmacy has become a norm. And I want to put a question to all of you. How many of you, especially those who have got the inpatient setup, acute manic excitement, acute mania, whom you have admitted, how many of you are willing to manage the patient only on lithium? Most of the time it's lithium plus. Why? We'll come to it a bit later. Prophylaxis, I don't want to go into the details, but yes. When you talk about treatment of mania, you cannot just stop talking on the management of mania and not talk about the further episodes because the recurrences are normal. But how do you stop it? It's a rational. Prophylaxis is rational, logical, very well intentioned. But the point is, this again, some of you may not agree. Do we have enough satisfactory, effective interventions, pharmacotherapeutic interventions today, which can reasonably promise that the next few years, I can promise you, you will not have a next episode? Doesn't seem to be. I'm sorry, and say that even lithium sometimes I include in that. That is where the prophylaxis definitely it is required, but do we have? It's a big question mark. Switch to depression. This is most of the time we talk about switch to mania. We don't bother about switch to depression. One of the problems is that switch to depression.
Somatic symptom disorder.
Right. This is. I don't know whether. Can somebody mute yourself? I hear some discussion. Yeah, thank you. This is a question which slide I put. In a patient with a diagnosis of bipolar disorder, a manic episode, I'm very particularly specifically putting any age group, gender episode of any severity, 6th episode, 10th episode, 15th episode, whatever may be the duration of the episode, whatever may be the frequency, with psychosis, without psychosis, can I, as a treating psychiatrist, achieve complete symptomatic recovery? Can I? Acute mania. Can I promise the patient and relative that you're going to recover? Your YMRS is going to be less than 8. My answer is yes, sir. I know there can be some disagreement in that, but still I say that yes, because bipolar disorder by its course is episodic illness. Recovery is the rule. And this is not out of some kind of, like trying to project saying that we can do all these things and arrogance, but it's only to give them a promising positivity in outcomes. That's the only thing. But I feel that this is possible. And one of my standard questions, which I keep asking everybody, is that quite a lot of your senior psychiatrists, what is the percentage of chronic mania in your clinical practice? I'm sure it's less than 5%, not more than that. And this is another slide which we all have to remember. Just I'll take a minute on this. This is the onset of mania. A patient, the mania has started, a manic episode. Suppose you don't touch the manic episode, you don't treat the manic episode, leave it like that. But a lot of times it happens. Suppose you don't treat the manic episode, at some point of time, it has to come back to normal euthymia. That is by definition, diagnosis, prognosis, that by crippling. It has to come back to euthymia. Whatever maybe the episode may be, like a duration, I know that. It can be very long, prolonged, but I'm saying that normal course of mania is that it has to come back. This is a natural course. It has to come back to euthymia. What we do with our pharmacotherapeutic interventions, whatever drug you give is that this time duration, we shorten it. We bring it here, which is very, very important. You can't leave the patient in this kind of a morbidity for such an extended period of time. What we do is that shorten it. Instead of 8 weeks, we make it 2 weeks. Instead of 12 weeks or 3 months, we make it 1 month, which is very important. We save the patient from this morbidity, from this episode. Why I put this is that number one, to emphasize that the natural course that is, they have to recover. We shorten it with our pharmacotherapy. Now, suppose you're doing a study, you're comparing, let's say, risperidone and placebo. Suppose your time frame of primary outcome measurement is 4 weeks at this period. Obviously, risperidone is far, far better than a placebo. There's no doubt about it. Suppose your primary outcome measurement is 12 weeks. Both risperidone and placebo are equally effective. So just basing on this, it's equally effective here. It's better effective. This is peculiar to the mood disorders. I don't think in other conditions you see this kind of a thing, because natural force itself is that all of us have to remember, because that's the reason quite a lot of times the evidence-based medicine give us the kind of medication which they say that it's very effective. When it comes to the clinical practice, we don't find them really very effective. Something like lurasidone, the drug I was waiting for, because bipolar depression is one of the most difficult things. But for me, it is very disappointing. I don't know, some of you can share your thoughts on that. Treatment of acute mania, till yesterday, this is the standard all over. Whatever textbooks say that, all of us do this. 95% of the cases we do. That's where I said that it starts with polypharmacy. Second is, I'm doing this right now. Some of you may question this, I'm doing this purposefully, I do only antipsychotic. How many of us treat only with a mood stabilizer and acute mania, unless it's a very mild mania, very minimal hyperactivity, even the grandiosity is not that much, and elation only then, even then, I don't know how many of us talk about only the so-called lithium valproate in these drugs. Now, this is the pattern all along as we're practicing. Now, I have another drug. The last drug which is specific anti-manic was lithium. Lithium was the only drug which is anti-manic. Lithium has done a pharmacological distinction of psychosis into schizophrenia and then manic depressive psychosis. In the last 7 decades, all drugs what we have in the management of mania is either antipsychotics or anti-epileptic drugs, also anti-manic, Now we have supposedly, God knows whether this drug is very effective and all. It's in a very, very early phase, but this has come into the market, Endoxyfen. Now the next step is whether we are going to combine these two drugs. That's going to be later, but standard practice is this. What we do. I'll just show you this slide. The 2015 psychological medicine, again from this now, like Edward Vieta, Barcelona group, the acute bipolar mania, that's what we are talking today, management of acute mania. There are 12 drugs of efficacy which have been compared. Network meta-analysis. Beginning with the most efficacious drug, the rank order for efficacy, that is, they have compared 12 medicines which we commonly use in the management of acute mania. The number 1 is the most effective. The number 12 is the least effective. If you look at this, the most effective drug in this network meta-analysis, at least according to this 2015 study, is risperidone. It's a monotherapy. It's not a combination. They're not talking about a polypharmacy. It's a combination. The most effective drug is risperidone. The least effective drug is valproate. Why are we using valproate? Why do we use valproate in left, right, and center in every patient in the management of mania? When I saw this, I was very happy because I have of late, this is my personal experience, completely personal experience. I found that valproate is no. It just doesn't do anything. That is where a few minutes back I said that I'm developing some reservations about the Kindling hypothesis also. Does it really happen? Whatever happens in the seizure disorder, is it really happening in the bipolar disorder? There are a lot of doubts. Valproate virtually is not. But then how can, Dr. This I discussed with a lot of our colleagues, they say that, no, it's effective. I have shown you just now, the so-called placebo response after 12 weeks. Possible. No, how can you say that, doctor? But this is what I'm saying, that risperidone is the most effective drug in this. We are not using haloperidol, but olanzapine I use. Lithium is also way down. Some of the recent data, I told you in that one of the bipolar disorders, 2019 study showed that in the adolescent age group, risperidone is more effective than lithium. So this is a drug which is an antipsychotic, and this is the most effective drug. But that's what is coming up like this. Right. Next, I have just another 3-4 slides. Here, slightly, I am migrating from management of acute mania to prophylaxis, and I just want to share 2 or 3 of my cases. This is a patient whom I have seen first in 1989. When he came to me, he was already diagnosed as a bipolar disorder, seen by one of my colleagues. In 1985, he had a manic episode. He was on lithium. He came to me in 1989. Even now, I see this patient. The next, till recently, he never had a single manic episode. He used to have a minor brief depressive spells. I cannot call him as a depressive episode also. So somewhere here, I stopped lithium. I continued lithium for more than a decade. Last time when I presented the case in a group, a lot of people even fired me saying that, why did you continue lithium for a decade? I know, I have answers for that. But somewhere here I stopped. Not a single episode. I do not know whether it's a bipolar or something. That's why I put it as, did lithium cure bipolar disorder? I don't know. This second patient I have seen, this is an youngster. He's just about 21, 22. I saw him in 2014. When I saw him, he was doing his MS in US. This is the first episode mania. He was brought here. His brother is a medical doctor. So I saw him in first episode. Not a very severe mania that I had got. It is a elated, grandiose mania. Started him on lithium and I think olanzapine. He recovered, and then I told him the way he can go back. He went back to US. And then in between lithium, I generally give up the 800 to 900, mostly in the 0.6 and then now like in 0.7 range. I usually don't go up to 1, but 0.6 to 0.7 range. I keep at least 6 months, definitely I'll do a lithium estimation. 2014 to 2021, I think the recent was a video consultation which I had about 3-4 months back. This boy did not have any episode at all. Last 6 years, 7 years. He's completed MS, he has got a job there, he's working there. He came 2-3 times here, he met me and then he continued lithium. Here, I am continuing lithium. Do you want me to continue lithium? He has been here for 6 years, he is without episodes. Do you want me to continue lithium? Or can we think that it looks like maybe the natural course of bipolar disorder, which I think one of the recent papers, Baldessarni has very categorically told in 2/3 of patients, bipolar disorder course is random and chaotic. He mentioned very clear. Only 1/3 follows a specific pattern. 2/3 of patients, nobody knows what will be the next episode. When is the next episode? What is the severity? What is the frequency? We have no clue. So do I continue this? If I continue this, how long I continue this? When I continued here and I told in the group, 10 years, they said that, how can you continue that? A drug like lithium. But in that, after 10 years, I took a decision. When I was taking a decision, I was so worried. If this man has a recurrence of mania, my God, what have I done? What did I do? But fortunately for me and for him, he did not. Now, what do I do with this boy? Now, I have another patient. No, it's not that you don't tell me that Dr. Reddy, you have just selected 3-4 patients and then talking to us. No. This is a representation of the patient, what I see in my clinic, in my data sheet. Umpteen number of patients I have this like this, month after month, year after year, with so-called prophylaxis. That's where I said that little bit of disillusionment. But what is the alternative? I know at present I'm not able to give. This is another patient I've been following even now. I think last year I presented this case. 11 years. He has been on lithium from day one, sir. Day one, he has been on lithium till now. And he has been in between on these other drugs also. This is one of those patients where I used antidepressant only maybe just for about a year, not more than that. Sometimes I do use antidepressants in the bipolar depression management. I don't restrict myself. But here, after 11 years of continuous use of lithium, I tell you, I regularly do lithium estimation. We have a clinic, we have a hospital, and then we do it in our own hospital, and then at least 4-5 months. Every year, at least 3-4, definitely they'll get, and most of them are above 0.6. I'll do the dose titration. This 11 years, this boy had how many episodes total? Yes. Yeah, this is 13 episodes he had. 13 episodes, out of which 8 manic episodes and 5 depressive episodes. This is also an youngster. Software, yeah, right, engineering graduate, software professional for 10 years, right, in between 2 suicidal attempts, and then this one. The other boy, just now I talked about at the same age group, first episode mania, 6 years, he is totally free. Completely no episodes. And this boy on lithium, he has got 13 episodes. How do we explain this? What are the biomarkers for me in this? Nothing in the family history, nothing in the past history, nothing tells me this is what you should do, this is what you can do. And here, the only thing you may be like obviously missing in this is not using valproate. In the last few years, I almost stopped using valproate because I find that it's really not working much. So these are the kind of cases when I find, what do I do? And then when I showed in one of my previous slides, I told lithium is gold, but this is a paper in American Journal in 2020. It's a study of like pattern of usage of drugs 20 years. In 97, then the late, this period, now like the late, last part of the 90s, 60% of the patients of bipolar disorder were getting the so-called mood stabilizers, which has come down to 23%. Why? Why are the practitioners, clinical practitioners, not prescribing so-called prophylactic drugs when prophylaxis is the rule? I think Dr. Malaidave was very clearly telling episode after episode, there's going to be neurological progression of the disease. There's going to be neurobiological scars. There's going to be worsening of it. Why are we not prescribing? Even lithium, it was about 32%, it has come down there. Why we clinicians are not prescribing the so-called prophylactic drugs? Obviously, this is very correct. First generation antipsychotics, I think none of us are prescribing, and then second generation has gone up. It's a trend all over. I think you all agree with me in this. Mood stabilizer prescriptions have decreased from 62 to 26% in this period. Why? And even lithium has decreased substantially. Lithium is, we all talk about this is the gold standard. We all talk about this is the drug. We all talk about this, revisit and then rethink about it. Whole lot of literature, but we are not writing. One of the reasons, one of the papers which I said recently, that everybody is worried about the side effects. I think as a medical practitioner, we should not be so much worried about the side effect profile when a drug is so very useful. Right, primarily by decreasing the use of non-lithium mood stabilizers, valproate and carbamazepine. This is something which I like. I am very happy with this trend. Some of you may not agree with me, but that is what it is in the management of bipolar disorders. This is the last slide. See, when we treat a patient, we need to have some metrics. This is the first, second stepwise metrics to show the patient, to show ourselves that this is the improvement. This is in 2020 bipolar disorders, illness activity, what is the cause? Here, typical response criteria, person-centered, they have very clearly differentiated. I mostly talk about symptomatic recovery. But the point what I try to drive is, patient has come to us with a medical disorder. Make him asymptomatic. With whatever the intervention you do, make him asymptomatic. Bring his YMRS to less than 8. After that, don't give him a serious adverse events. You take care of these two, Functional recovery, I feel that most of the case is a logical consequence. Everybody wants to go back to function unless something interferes with them. So here quantitative, I was telling you initially is activity, cognition, and then now relation, either A criteria or A and B criteria. What is the criteria you're selectively looking at based on that? Qualitatively, we broadly talk about response, remission, recovery, and then now how long is the duration of the episode? What is the inter-episodic, that cycle length? This is how the metrics are done in the management. Let's not talk about this. The criteria for determining treatment failure, we're not talking about. Here, person-centered response criteria, this is functioning, quality of life every patient wants. Patient-defined criteria. Patient is not just bothered about, he is bothered about the asymptomatic state, but something more. Return to work, avoidance of admissions, to what extent we do it. These are all the goals which we have to try to achieve. These are the metrics we need to measure in the management of acute episode. I say that management of acute episode is the most important thing. Why I say that you manage an episode of acute mania well, get him back to asymptomatic state, get him back to functionality. That will be the first step in your major step in psychoeducation. You are giving the confidence to the patient that, hey, you have an illness which is recoverable. You have an illness which we have tools to manage and then treat you, manage you, go back to work. Not just by telling them, we are showing it, saying this gives the patient and the relatives confidence. Yes, this particular therapy, this intervention helps. There's nothing to worry. It's like tuberculosis, it is curable. This episode is curable, even in the next episode, right? We should be able to manage. That's the kind of confidence they should go back. So the primary, what I talk about is that the primary episode, the first episode management is very, very crucial. Complete recovery, that is very crucial. We should get all our efforts in that direction to make the patient totally recover state, symptomatic recovery. Obviously the functional recovery will follow. Yeah, this is the same slide which I showed you in the beginning. We can have some discussion. As I told that I cannot talk about a specific drug for a specific indication, what I talked about, but broadly, how do you choose a particular drug in this particular thing? With broad comments, I say that, how do you treat the first episode mania? And how do you treat a 10th episode mania? I don't find much of a difference. Mania with psychosis, mania without psychosis, really not much of a difference, because anyway, every patient we are using an antipsychotics. It is something like that. Prophylaxis, I do it, but I'm really not very happy with the outcomes, not very confident about it. So, but the management of mania is, I told, yes, will my child become all right, doctor? Will he become completely all right, doctor? Yes, there's no doubt about it. That really positive note. Thank you very much for your very patient time. Thanks. Now over to you, Dr. Atul. Thank you so much. Dr. Asin, I'm sorry.
Hi. Thank you so much, sir. I think Dr. Jyoti will take over now. We'll take all the questions from the audience. Ma'am, you can take over.
Yeah. Am I audible?
Yeah.
Yeah. Thank you very much, Dr. Dave and Dr. Reddy. It was really excellent presentation and lot of feast, as I said in the beginning. We have some question in the chat. We'll take that first. Yeah, there's the one question from Dr. Ashutosh. He's put it that anti-manic choice in morbidity in obese 45-year male patient with alcohol dependence, advanced liver cirrhosis, and seizure disorder on brevitiracetam, topiramate, clobazam, and OSA. And QTC on ECG is 470 milliseconds. So he wants to know. He has also put it as pattern of alcohol consumption suggests that bipolar disorder is there. And currently patient is on escitalopram 5 milligram, naltrexone 12.5 and melatonin 5. Yes.
Yes, madam, I could read that. No past history of mania, presently in depressive episode.
Right.
So it's actually, you would like to treat him for depression rather than mania.
Right.
You're asking me what is the treatment of choice for depression. I told you bipolar depression is one. Unfortunately, it has become the most controversial topic today in psychiatry. God knows when we are going to come out of it. His patient is already on escitalopram, but you said 5 milligrams. So this is again what happens. The least possible dose for the least possible period of time, you can give antidepressant. What are we doing? You want to treat him or you don't want to treat him? So this is what guidelines tell us. That is where I can see that. So here with all this, see, I am one of those who do write antidepressants in this kind of patients. I would say that to manage, depression, you can go up on escitalopram, at least 10 milligrams, slightly high. If you're not very comfortable, I don't suggest quetiapine in this kind of with all other problems. I'm not looking at lithium in this kind of a patient with so much of a medical comorbidity. For mania, I can talk about giving risperidone, reasonably non-sedating drug, maybe at a low doses. That's what my choice is. I would treat him with risperidone. I would request others also to share, if they have any specific suggestions in this, because it's a very complicated comorbid case. Cirrhosis of liver. And here the point is, maybe I'll take another minute. Is the substance use is a comorbidity or it is secondary to bipolar disorder, which is going to be very, very important here. If I say that it is secondary to bipolar disorder, I would venture out and then talk to the patient relatives and then little bit dare to start lithium, at least for a short period of time, give him the benefit of it. If it is not secondary substance abuse, which is sometimes very difficult, I may not. It will be very difficult for me. But it depends on sometimes it depends on how understanding the patient and the whole family is, and then how they are going to walk with me. That depends on that. To start with lithium, give him the specifically as an anti-manic, no. If it is going to be future episode prevention, I may try it. Otherwise, risperidone, I would go for.
Yeah. Dr. Malay, you would like to add something here?
No, for this patient, well, since he has never shown any clear-cut symptoms of mania, I would hesitate in starting lithium, that is definite. Since the current symptoms are depression, I think it's worthwhile hiking up the dose of escitalopram to whatever 10, 15, 20, whatever is needed, because that I think is the safest bet at this point in time. Now, if sir doesn't like that term of anti-epileptic mood stabilizer, but he's already on 3 anti-epileptics, and if they are not stabilizing the neurons very well, at least from the seizure perspective, I don't think what else is going to really bring about the stabilization bit. So as of now, I think hiking up the dose, escitalopram is the thing. Secondly, this pattern probably could also be a binging kind of a pattern. I'm not sure whether it is falling into the mania or hypomania kind of a thing. Anyway, I think first treat the depression. Let's see what happens.
Yeah.
I think, but he has given a suggestion that last sentence is pattern of alcohol consumption suggests bipolar disorder, 2-3 months of heavy consumption, then sober for a few weeks. Here, I will have a long chat with the family and then the patient, and then give a trial of lithium, because already in cirrhosis, if something can help him, let's see.
Yeah, in fact, actually, lithium would be a good choice if at all an anti-manic, because even with all these things, lithium is not going to add to the physical comorbidity or worsen any of the parameters, except tremors if he gets it. But I think if you're giving us little dose, I don't think that should be a problem.
Yeah. Anyone else from the audience would like to ask the question? Either they can chat or unmute and ask the question.
If nobody has questions, and then if time is permitted, I would like to ask some of you the point what I told, a mania. Are we all in agreement saying that yes, your mania will recover, or you don't agree with me? It's an open question, man. I just want to learn, because this is sometimes people ask me, no, you're making really overshooting, Dr. Reddy. I said, yes, purposefully I'm overshooting. There's only one condition in psychiatry, the mood disorder, which can at least promise a reasonable recovery to the patient. At least let us do that. Natural course itself is getting into euthanasia. Why are we holding it? Give them the benefit. You do a little bit of it, facilitate that, and then show them. Why are we meddling with polypharmacy and then ending the patient with a whole lot of side effects? That's what I say. That I don't know. No. Feel free to disagree.
What I practice generally is I always talk to the patient is recovery for this episode. Try to have that balanced, attitude that, it's not long term, it's not the complete cure as such. But recovery for this episode, definitely we can work onto it, and that can be promised. But we don't know if person is going to get again the relapse and recurrence of it. So that's what generally I convey to the patient. Yeah, Dr. Malay, what's your opinion?
Yeah, I mean, well, in some patients, the recovery is not, most of the times, the first manic episode does turn out quite well. Patients become completely asymptomatic back to their lives. They do have repeats. Some of them just keep on having manic episodes. That's mentioned that unipolar manic polarity in some patients is definitely there. Some of them do have recurrent manic episodes, nothing else. And some of them have manic episodes which go longer than probably what we see in majority of our patients. We need to be prepared for that, but at least, well, if we can reduce other morbidity in terms of side effects, or well, we don't give them more sedation than they want when it comes to their working, I think we are doing good.
There's one more comment here, madam. Recovery is temporary until next episode. So what's up? The next episode, suppose it's after 10 years. Are you not happy? I'm happy. Even the textbook says that there's only 4 episodes in 10 years. So one of my patients had 13 episodes, that's a different story. But only 4 episodes in 10 years, that's what most of the textbook says. So next, if you average out, 2.5 years, the patient is asymptomatic. Why are we not sort of happy? Prophylaxis, actually, I was fired by one of the delegates. Dr. Reddy, you're talking about this. Don't you think it's unethical not to talk about prophylaxis? Absolutely. You have to do prophylaxis, but do we have the tools? Without having a definite, including lithium, quite a few patients I'm talking about, your patient is on lithium, they keep getting the episodes again and again and again. That's what my worry is. Yes, madam, I should not be talking so much. Over to you.
Sir, while treating acute mania, automatically at a spinal level right now, we start a mood stabilizer and second generation antipsychotic. You spoke about treating only with a single mood stabilizer. How much in your practice are you able to manage the acute episodes?
No. I think it's slightly reverse. See, what I told is that I almost don't, because I don't have the confidence. I deal with only antipsychotic. The patient with acute mania, first episode, I give only risperidone. I give only olanzapine and treat it and then forget it. Wait for the next episode, for which there is criticism. How can you do that? But I say that how many of us are capable of managing only with lithium? Forget about valproate. We are not.
Correct.
Then why are we adding lithium? Prophylaxis. Prophylaxis, second episode can be after a few years. Why are we starting? This is what APA guidelines say, that anyway they are going to have the second episode. Might as well start from now. You saw 2 of my patients. 2014, next episode is not there. But a lot of you say that it's because of lithium, which I'm giving lithium, but I'm not really very sure about it.
Maybe we need to have long studies on that in the future.
Exactly.
Do some research, right? Comparison between not giving any medication and giving lithium and see how much it works.
Crossover, man. Mostly crossover studies may help, but that is going to be a difficult task.
Yeah, so I think we had real great discussion and real nice presentation, very excellent presentation. Thank you, both of you, Dr. Dave and Dr. Reddy. And yeah, Priyanka, we can end it, or you have any announcement or anything to be made?
Thank you so much, sir, Malay sir and Reddy sir. It was a privilege hearing so much about bipolar disorder. I think the genetics to the medications, it was a great insight. I thank you all for attending the session, though it got extended, but still the participants were there. So I'm happy that people were listening to it very religiously. The last thing I have to say is tomorrow, for all the people who are attending, tomorrow we have a CME on rehabilitation in psychiatry, which is a 3-hour CME with 1 credit point from MMC. I would request everyone to join tomorrow at 6 p.m. I've shared the link via emails and the registration forms. So if no one has got it, anyone has not got it, please feel free to email me at bpssecretary2013@gmail.com. Thank you so much. Have a pleasant evening and a good weekend. Thank you, everyone.
Thank you. Bye.
Thank you.
Thank you so much, Reddy sir and Malay sir. Thank you so much. Thank you.
Thanks, everyone. Thanks. Good night.